The doctors, the nurses, the therapists that see these patients in the acute care setting, they become attached to the patients the same way we do, over the course of their rehab stay here. A lot of times these patients were in the ICU for weeks on end, and it's the same providers or nurses seeing these patients day after day after day. And so, we do try to really follow up with those teams and let them know when we see these, inspirational outcomes that we see every day here. It's a matter of kind of showing that gratitude that they entrusted us with their patients and the care of their patients, but also to let them know, you are a part of this outcome. And it's so true. If for my consult service, the U of M team, they deserve, we share the credit, with them when we see good outcomes there. They're absolutely a part of the rehab journey.
Welcome to The Summary, a podcast from Mary Free Bed, where we explore physical medicine and rehabilitation, one topic at a time. Together, we will gain insights, discover innovations, and deep dive into the latest developments in the field.
I feel like today's topic is something really near and dear to us, and it's like a really hot topic in our hospital, actually. We're building a new pediatric hospital, Joan Sekia. I think it's opening, 2026 October?
Yep, in the fall, summer. Yep.
And naturally, because of that, we're trying to increase our patient basis. And so consult has naturally been something that we're really focusing on. And I kind of got to dive into it alongside with you, being in the peds world. And wow, it's a very complex, delicate, but also like filled with different opportunities and excitement. And that's why I kind of wanted to talk about this topic.
Yeah, and here at Mary Free Bed, we admit, 15 patients a week, not to peds, but adult and peds, and from several different hospitals, and some of them a couple hundred miles away. And it's, like you said, it's a very complex process, and we're doing a lot of it, and it just takes a lot of people with different expertise, and I feel like we've really fine-tuned the process and built up a consult base at some of the other hospitals, and so we want to talk about how to start from scratch and build up a consult service, but also kind of how does that process work, transferring patients from acute care to inpatient and doing that as efficiently and quickly as you can, but also at the right time so patients aren't bouncing back.
Yeah. I think one of the interesting things, because I've done most of my training in a standalone rehab hospital instead of like doing it in an acute care hospital incorporated program. And because of that, I never really had to like prove your worth or explain what do you do as a physiatrist? Like what are your skill set? And now that we're doing consults in the acute care hospital, I've come to realize like, oh, that is something I need to learn how to explain and actually like demonstrate too.
Yeah, I feel like I don't even want to say the word physiatry. I say I'm a rehab physician, so that takes a few steps out. But we've got two fantastic guests to talk about this topic here.
Dr. Chris Rizik is our medical director of Inpatient Access, and he also specializes in spine and musculoskeletal care.
And Holly Banninga is our director of Inpatient Access at Mary Free Bed Rehabilitation Hospital. She brings deep expertise in healthcare access management with Medicare and process improvement. She holds an MBA with a focus in healthcare management from Baker College, and she is the chief person in charge of our Easy Button. More to come on that.
So Chris, how did you kind of get into the consult world? Did you my understanding is that you actually went into a hospital that we didn't have a consult base yet, and then you kind of initiated that whole program. Can you explain a little bit about that?
Yeah, how I personally got involved in consults is kind of a loaded thing. I joined Mary Free Bed coming out of like a interventional spine fellowship and musculoskeletal medicine. So it's probably a lesson in, being willing to accept things that you didn't expect in your practice. But when I joined Mary Free Bed, COVID hit, a couple months after. And so our outpatient clinics closed and we were all, in a very different practice situation than what we anticipated. So I was actually approached, I think about 7 or 8 months after I started with Free Bed. And the administration said that, we think we're going to have this opening at one of our acute care hospitals with the consult service. Would you be willing to take this on? And I said, sure. let's give it a try. So that hospital was then Metro Health in Grand Rapids. Since then, it's changed names to University of Michigan Health West. The cool thing about that hospital is that, there's this deep relationship between U of M Health West and Mary Free Bed that's been present for, I think, 50 plus years. And the really unique thing there is that there was actually a rehab unit within Metro or U of M not even that long ago. And so a lot of the therapists that are still there in the hospital actually worked on this rehab unit. And so there really is this culture of rehab within the hospital. The therapists, as you guys probably know, are actually contracted by Mary Free Bed. And so there's this, actual tangible connection between the two hospitals. And so, as we built up that consult service, really everything starts with the therapy team there. I think because they have this culture of rehab that's kind of running through their veins, as we integrated more with their team, talked about what makes a rehab patient, what are we looking for, how many patients can truly come to Mary Free Bed and benefit from it and thrive and get great medical care and great rehab. It's allowed that relationship and kind of our overall rehab program to really blossom and grow there.
So Holly, what was that like? I mean, we'll talk about kind of the process in general, but to start off at a new hospital and get that ball rolling from your standpoint and your liaisons. And
it's all about developing relationships, getting to know each other, understanding their challenges and how we can solve that problem for them. Hitting the easy button anytime we can to make life easier for their case managers. Having liaisons that are willing to jump in and get to know patients and families and ask the tough questions, because liaisons' roles really is to support the recommendations of the consult. So when a consult is completed, it's not completed yet because we have so many extra layers that we need to support with conversations, with setting expectations, with making sure that we've got all the information we need to then request authorization. These steps all take a lot of time, but relationships is really at the center of it.
so Chris, how did you kind of build those relationships starting from scratch, and did you have to explain what PM&R stands for?
Oh, you know what? Over and over, and still, still we do that. I'm sure you guys can identify with that. So, it really was a day-by-day thing. I think Una made a great point early on that we're a standalone hospital here, a standalone rehab hospital. And so, we don't have all the acute care specialties walking our hallways here, seeing the way we treat patients. What they know is that we get great outcomes here. They know our reputation that's been earned over 100 years. They know that patients come here and do great, but they don't see the process. They don't see the day-to-day. And so, we have been very intentional with making ourselves present in the acute care setting, being there day in, day out. When we see a consult, even if the primary question being asked is, where should this patient go? What kind of rehab does this patient need once they're ready to leave the hospital? We try to chip in and do our part, with clinical management of patients. So much of what we do, kind of falls in the cracks and crevices of medicine. It's not the most forward thing in the hospital always to manage spasticity or to manage bowel and bladder output for a patient that's had a neurologic injury. And so, by being very intentional with involving ourselves as much as possible in the management of these specific features of patients, we're able to demonstrate that, we can provide care, we can help with the management of acute care patients. And then when it's time for the patient to go to rehab, we've got a very good situation lined up for them.
Yeah, I feel like dispo planning is one of the majority of the consults, and that's kind of the big way that people think about PM&R. But like you said, there's so many other things we can actually manage clinically while the patient is still in the acute care, other than admit to inpatient rehab, right?
Yep.
Yeah.
Yep. And I think it's on all of us, to make sure that the specialty doesn't devolve, into a glorified discharge planning service. It's on us to do the full exam that we would do for any patient in our hospital, to give sound and robust recommendations on how we can help this patient. And, I think what we've seen is that when you do that day after day, they start seeing you as a resource, the acute care, referring teams, and they start coming to you specifically for management of these other clinical problems.
I think one of the things that I always feel really awkward about is, for example, neurology is managing spasticity. And then I'm consulted in for, dispo management. And then I'm like, do I comment on this? Do I not comment on this? Or do I just say neurology managing spasticity? Like, what would you do? Like, what do you do?
Sure. I would always recommend doing your full exam, your full assessment, and putting forth the best recommendations you've got. And there will be times where the referring team then calls you and says, "Hey, Dr. Sinsky, you made this point about this problem, about the spasticity. What do you think? Or can you handle this, at Mary Free Bed, or do you want to see this patient as an outpatient in your clinic, for Botox or whatever it may be?" So I would say keep it up. Keep those recommendations broad and robust.
Okay.
Anything that generates discussion with the team over the other hospital just builds relationships and trust and more consults then, because they get a better understanding of what we do.
Right. Teams, I don't know if you guys were able to do, PM&R rotations, early on in medical school, or what the education was like, but a lot of students go by, through their schooling without any exposure to PM&R. Our residents do the same. And so, those teams don't just know inherently what we do here, what we can manage inpatient or outpatient. And so it does take education and time, and really trying to, invest yourself, in their day-to-day work life. We have gone on to do a lot of resident lectures for internal medicine teams, surgery teams, trauma teams. We have regular talks with the therapists at U of M, just to kind of stay in everybody's sight and to keep the dialogue open, and to let them know, you guys are helping us so much by, getting these patients to us. We want to do the same for you.
Another thing that both of you kind of work with, there's the recommendation to come to inpatient rehab, but then there's like, when is the right time, and when are they medically ready, when are they physically ready, and how do you guys work with that with the team?
We communicate all day long on patients and where they're at, and waiting on authorization, getting the ride set up. It's an all day long dialogue between our team, but then even more so with the teams in the acute care hospital. We have to communicate sometimes in the chart because it's okay to have a conversation, but the whole team doesn't have access to that conversation. So where are we at? The last thing we want to do is appear to be a barrier or slowing things down. So the more we can show our value by being present on the floors in the hospital, having these conversations, the better for us.
I think another answer to that question is to actually kind of move back a little bit and look at something that's kind of developed within our access team is to ask for early consults. The earlier we are able to establish with the patient, get our baseline, neuromuscular exam on the patient, track them day to day, establish with the patient's family, it allows us to get more comfort with kind of the track that the patient's recovery is on. You've probably heard something about the difficulties we all experience nationally with insurance authorizations for some payers. And so we try to get the ball rolling as early as possible. And that also allows us to make that determination when we think the patient is ready to come here. And Holly's absolutely right. There's constant dialogue between our team and the acute care teams, the therapists saying, hey, did you see something different with the patient today? They performed much worse today. Are you seeing a neurologic status change? Is there something we need to look into here? More visits with the patient, more dialogue with the various teams seeing the patient. That's what we look for.
Holly, in the administrative standpoint, what were some hurdles that you saw when we were actually starting to work like newly consults at then Metro, now U of M West?
I think probably the earliest challenges was just having them think of us early on, really. When we get a referral or a consult the day the patient's ready to discharge, everybody's feeling rushed. And we don't want to put the patient in the position of feeling that way or the family. It's a big decision, and a lot of these families don't understand post-acute. So probably providing education about what post-acute actually is was one of the first steps that we took. I'm thinking that's one of the first presentations we did with the therapy team. As a therapist myself, I don't remember learning about that in school. So when I got my first job in a long-term acute care hospital, I didn't exactly know what that meant. So we've got to assume there's a lot of basic knowledge around that, but every level of care has such a unique criteria, and it isn't just black and white. There's like all of these gray areas. So we stepped into that space and tried to help teams understand from our perspective what's a patient that might be eligible for acute rehab, and if they're not, how can we support them in their journey to that other level of care?
Yeah, I agree. I tell our trauma team, I want to see these patients when they're still on a ventilator. They're not doing anything, but like you said, I like to see kind of what's improving and what kind of rate. That gives me an idea of prognosis, but also get to know the family early on and talk about rehab early on. And, that's a complex thing, and there's different levels on the adult side of rehab and explaining that. I think that's critical to getting the patients over at the right time, because if they consult us when they're ready and insurance takes 2 days to authorize, you've lost 2 days. That hurts the acute side, it hurts our side, it hurts the patients with the delays.
What is the average number of days? I know there's no average, but just like in general.
Yeah, so we measure a lot of these things and look at them closely, sometimes by different hospital systems, by different diagnoses, but we call that onset days. So the date the patient admits to the hospital or has their injury is typically the same, but it's truly the date of injury to the date they admit to our rehab hospital. Onset days nationally are around 14, 15 days.
That's longer than I thought.
It does seem longer.
That seems really long.
Yeah. And for Mary Free Bed, we're at about 13 and a half days. So we're operating as a whole a little lower. But like for U of M Health West, for instance, we're at more like 8 or 9 days. So we look at our level of integration and we can celebrate that with U of M and show them we are very efficient together and patients are getting rehab a lot earlier, which is better for their outcomes.
Yeah, in pediatrics, our numbers are even better than that, which speaks to kind of the whole team process we have. I think that's what makes getting to rehab much more efficient. You got so many people working on things and getting updates throughout the day on lab results or conditions. And the other thing that you guys have to look at is this patient improving too quickly and they don't need acute anymore.
Yeah.
I feel like we see that a lot in kids. They just like bounce back, which is like wonderful. But then you're like, oh, wait.
Yeah, some families really struggle with that because they've been looking forward to rehab.
Right.
And it can be scary for peds and adults to take a person home who just went through a really significant illness. So that's a conversation that we have as well, that you may progress to home, and then how can we help them plug into services that will meet their needs from there?
And every hospital has a liaison?
Yeah, multiple.
Okay,
Our teams, our liaisons feel like as much of a Mary Free Bed employee as they do at the acute care hospital, because they're interacting with those teams every day, and they're working in that hospital because that's how we're best utilized.
Yeah, I think that can't be overstated. The role of the liaisons that we have here, the number of liaisons that we devote, to all of these individual sites, that is something that really makes Mary Free Bed unique, across the country. Just with our Grand Rapids sites, we have 4 liaisons for U of M West, 6 for Corewell, and 3 now for St. Mary's. And these are individuals who, again, are integrated within the hospital day in, day out, having those communications that you talked about, between acute care teams, case managers. They help us so much by reaching out to family almost immediately after the consult's placed. As we're evaluating the patient, they're reaching out to family and trying to get this picture of what home is going to look like for the patient. It is it's a struggle sometimes to get patients over to rehab for all the reasons we talked about, the insurance authorization, the clinical complexities that can come up. But our liaisons do so much to ease that process for us. That is something that's really unique with our setup.
Yeah, absolutely. I don't know what I would do without Janine. Like, I always know. Like,
Yep.
I talk to the right. It's like there's nothing we can do on our own, and she's just like there always. Like, I ask a question, she knows exactly what's going on or who to contact, and yeah, she already knows the family so well, and that has been like exceptionally helpful. But what I'm hearing is that's not the case for other hospital systems to have a liaison.
Probably more of an intake person. They may not be clinical. So our liaisons are nurses, PTs, OTs. We have speech and language pathologists. We understand rehab. And it's not just filling in demographics. It's a lot more than that. Yeah.
Well, and that is a big contributor to the success of our hospital. We've got usually 140 patients in acute rehab, and we're a freestanding. We don't get automatic referrals from down the hall.
Right.
We bring them in, and so that's a big portion of the success. Like you said, pushing the easy button brings patients in.
Yeah.
Yep, and you do hear case managers say that in the acute care setting that, we love sending referrals to you, because you take it on from the second we put that order in, and it is the easy button. You take over every aspect of this patient's transition to post-acute care, and so it's actually much easier for them to send patients, our way, as opposed to some subacute options or other post-acute options.
Yeah, I remember when I first started doing consults, my now husband, so that's just got married.
Congratulations.
So Nick was always saying, I said I've never done a consult before or been a consult or building a consult team, and he said, your answer is yes. You're not always saying yes to what they want you to say yes to. But the question is, yes, I will see the patient, evaluate the patient, and figure out a way to help with this entire clinical process. And that has been so helpful. And it automatically put me in the mindset of yes, I will see this patient, and I am going to figure something out, or at minimum, give them an encouragement or have somebody to talk to while they're in acute care stay. Because a lot of our acute care colleagues, they don't have the time we have at times, or the just being able to kind of almost palliative care at times is how I see it. And to me, that has been so rewarding. Yeah.
Yeah.
Yeah, I think it's an attitude or an approach that we all try to carry with our consult services, that we will see any patient that you'd like, our eyes on, and we are happy to help. We'll try to find some way to help every patient that we see. If it's a patient that's had a devastating brain injury, okay. If it's a patient that has pain in their big toe, we will see that too, and we'll do the same really thorough exam that we're going to do, and we'll try to find a way to help that patient through their hospital course, whether or not they're going to come to Mary Free Bed thereafter.
Yeah, we don't say no to a consult or a referral. So not all of our patients that admit to Mary Free Bed come from our local acute care hospitals. We get referrals from all over the country, and we look at every single one of those referrals as a consult. So liaisons have a completely different role there, but still advocate for those patients. And if it's, we can't help you here, maybe we look geographically, where can they get the care that they need if their family's unable to travel. So we just try to be a solution for every patient. We convert to admission less than 50%. So if we are targeting and hoping to admit 3,000 patients, we're probably receiving referrals and consults on 6,000 or more. That takes a lot.
That's a really high volume.
Yeah, it's the real volume.
Because we just admitted a patient from Hawaii.
Yeah.
Right?
Yeah, we did.
That must be a much more complex process.
Yes, air ambulance travel, is not only complicated but expensive. So we work with families to help those logistics, but there's a lot of great flight companies we've developed relationships with, because that's just one more piece of the puzzle that we want to go smoothly. We brought a patient from Maryland yesterday. It just, they are hearing about Mary Free Bed and what we do here, and our outcomes really shine.
That's awesome.
Yeah.
That's exciting.
Yeah, and I want to go back to, like, how many liaisons do we have, roughly?
In the system,
Yeah,
I think we would say around 60.
60.
Wow.
Yeah.
So that's a huge cost for Mary Free Bed, but it's worth it. I mean, we keep 140 beds full.
Yeah, and we support our admitting teams by being the eyes and ears at the bedside. We pass along such
Yeah.
valuable information, so when the patient gets here, it's not starting back at zero. They have their story already packaged, and the team knows where to pick up. And that, for a patient, feels really good.
Has it always been that way that we had the liaisons, or when did that shift happen?
Before my time, but the structure of access has really changed. We've got more support on the front end, so we don't do all of the pre-registration and the insurance verifications and the insurance authorizations. Those are specific teams within our access team now, which helps everybody operate so efficiently. Our liaison team, I think, started as a team of 1 or 2. And they would
Wow.
perform more like intake. They would see some patients bedside, but just didn't have the time. And I think consults were completed at the very end of a physician's day as kind of a, okay, now I need to go, and it's completely different now. You can speak
And
to
kind of as a one-stop evaluation as well, and then the liaison would take over from there. What we've tried to implement is more of a true service, that you see within the acute care setting, where whether it's the general surgery team or the nephrology team, they're seeing a patient day after day after day, charting the progress, charting what they're looking for before the patient's ready to be medically stable, or in our case, to be released to the next level of care. But yes, having that devotion of resources is pretty unique for Mary Free Bed across the country. Having half-time or full-time consultants, even is pretty unique. There are, believe it or not, there are acute rehabs all over the country that take in patients just on chart review. A physician, reading through faxed papers or electronic medical records of a patient at some other hospital, and they bring the patient in, based on that decision-making process, which of course can work, but when we are able to integrate into the acute care setting, we see it as so much more valuable, and we see it as something that builds, allows us to show our worth, as you said.
It's like a warm handoff too,
You got it.
for the team here too. There's like, okay,
Yeah.
they've been thoroughly evaluated. I know this person who is admitting, and then we're going to bring him over.
Yeah, a lot of times I'll look at the papers, the notes, the progress notes, and then the patient comes, and patient doesn't always look like the paper. I mean, sometimes they look a lot
Exactly.
better, sometimes they look worse. But to have that person on the other end with eyes on and being able to talk to the team to get what's really going on, which isn't necessarily in the chart, very helpful, again, in bringing the right patient at the right time.
Yep.
So you guys, your team is like the easy button for us physicians.
Absolutely.
There's nothing we like more than an easy button.
We all do. Yeah.
Is there something that we as like physicians, like physiatrists, can do better for your team? Is there some things that you would like the listeners to know?
Well, listeners have to have a team
Yeah, that's
like
true.
yours to
That's
work with.
true.
Yeah. Yeah, I think maybe to answer the question a little differently, we appreciate the open-mindedness. Our philosophy is, why not? And I would hope that everybody would provide the same philosophy when they're looking at patients as acute rehab candidates. They don't fit in a box. They're not going to be a perfect fit for acute rehab. Push a little harder to find a discharge plan that might work, because that's probably the area that's the stickiest for us. We really don't want to say no to a patient that needs us just because they don't have a perfect discharge plan. But it's our job to help position that patient to have somebody that can help them. So I would say push the boundaries a little bit.
Yeah, the the discharge of every patient here is not going to be the same. It's the goal for every patient can't be to walk out of Mary Free Bed on 2 feet without an assistive device, as we watch them do so independently. We try to be as creative as possible with finding solutions for patients. It may be in an atypical way or with a modification here, a home modification there, but we try to find a way, to get them the best disposition possible.
Wait, Doug, how long have you been in the field?
30 years.
Okay, so then how do you see the changes in the consult world, in the PM&R?
Well, and I've been at a few places in my 30 years, and I've never seen anything like this system that we have here, which is why I've never seen any kind of census like we have here. I mean, really. I mean, I do peds, but in Cleveland, for example, initially we were the only rehab unit in all of Cleveland area, and our average census was 4 to 5. Same thing in Detroit, all of Detroit. Average census is probably 4 to 5, and here our ped census is about 12, and we're in little old Grand Rapids. That's because we have a team and a network and good outcomes. I mean, you do good work, people notice. So, we have pockets of the country that we've done a good job on a couple of patients. Okay, they just keep sending them.
Mm-hmm. That's a part of what we do too. We meet with administration in hospital settings because they need to know. They don't know what to look for. They just know the patient left. Mm-hmm. But showing them the patient went home, and here's the update card that celebrates what you did and what we did, and this is together a great ending for a patient story. So we bring that to hospital administrators to show them the value there too.
And that's like a card that has the patient photo on it and explain how they're doing and things like that, right?
And they're dressed in their own clothes. They look like an entirely different patient. But we provide that for the therapists, case managers, even providers sometimes that refer patients to us so they can see that.
It's a great point. The doctors, the nurses, the therapists that see these patients in the acute care setting, they become attached to the patients the same way we do. Over the course of their rehab stay here, a lot of times these patients were in the ICU for weeks on end. And it's the same providers or nurses seeing these patients day after day after day. And so, we do try to really follow up with those teams and let them know when we see these, inspirational outcomes that we see every day here. It's a matter of kind of showing that gratitude that they entrusted us with their patients and the care of their patients, but also to let them know, you are a part of this outcome. And it's so true. If for my consult service, the U of M team, they deserve, we share the credit, with them when we see good outcomes there. They're absolutely a part of the rehab journey.
Yeah, I love getting the little cards. It makes me so happy, and I keep every single one of them. I'm like, yeah, I remember you.
Yeah. In my daughter's very early days, she was not a patient, but she was an outpatient patient. And one of the first days I was here, her therapist contacted me and sent me her patient update card. And it was so cute because she had speech praxia. So she wasn't talking at all and nobody could quite unlock it. But one of our outpatient therapists did the first moments of meeting her. And that's how she got her voice. And that was really my first introduction to Mary Free Bed. But I still have that little patient update card of my daughter because it was sent to the pediatrician to show him, thank you for referring to Mary Free Bed. But that's truly a pivotal point in her life because she wasn't able to talk. So we all have our story, how we're connected here, but that's what drives our passion to do what we do every day.
Well, that is probably one of the most effective and cost-effective marketing techniques is just showing your results. We have patients in the peds world, I know, that come from a couple hours away. They come to us unresponsive. And I know all the people in the acute care wonder whatever happened to so-and-so. And, a lot of times they walk out of here and the other hospital is just amazed at the outcomes. I mean, that's the best marketing in the world right there.
Yeah. And a lot of those patients wouldn't have had a chance at another location because,
Yeah.
they were so low level. So it makes us really happy when we see those stories too.
Absolutely.
Yeah.
So when we talk about going to a different hospital, how do we identify a new hospital? What does the process look like that?
Oh, that's a good question. Interestingly, there is a metric called IRF utilization, so inpatient rehab facility utilization. And we have a team here that looks at systems, looks at hospitals that have a lower IRF utilization. And why would that be? And how can we be a support for the patients that need us there? So they'll connect with that team and share with them what we do and where we think they should be as far as how many patients should be discharging from their acute care hospital to an inpatient rehab facility. And then there's the introduction. And from there, we'll develop relationships and really focus on the patients that they're missing. And that's how we kind of explore that relationship.
Is it typically a warm welcoming, or is it like, whoa, it's a little skepticism?
But nobody likes to be told you're not doing a great job. So I think it's all in the message. And we have such an amazing mission here that it is easier to go in and say, we want to help your patients have better outcomes. And not only that, help you move them through your system faster and help them get home and stay home and not readmit. So using those data points are really key.
So you can see how many discharges a hospital has and how many of those discharges went to acute rehab.
Yeah.
And does that ratio, the expected ratio, vary with different types of hospitals or geographic areas?
It definitely can. We expect certain IRF utilizations from a level 1 trauma acute care hospital versus maybe a rural hospital with 8 or 10 beds, that doesn't have the same patient population. I would say within our access department, we kind of strive to see that number of 3% as the IRF utilization. That typically tells us that we're well integrated, at the acute care site, where we have the consulting team, the liaison team. That tends to tell us that we're doing a pretty good job in getting a good and diverse population of patients.
That's higher than I thought, actually.
Yeah.
3%. Yeah.
We're higher than that in some systems, and it's because of all the time spent developing the understanding of what we do and the patients that we can serve.
And we manage rehabilitation units in a lot of different hospitals. And really, it's kind of your same team, right? And most of the time, that's kind of going out and evaluating patients and bringing them in some way. And how is it different with a unit that we manage out of state, out of Michigan?
First, we need to understand their payers and their system. We've got some rural settings where it looks very different there than it does here. There's a wider reach for patients because they're traveling to these centers because that's the only hospital they have. So understanding payers and the patients and their abilities to actually be in rehab and developing those relationships to show them that they are a special hospital and we want to help them. Access is probably the first thing that sells the services that we do.
I guess this is a little bit slightly different topic, but what about bringing patients in from home?
That's a great question. We do that. And we probably do it better than most because we are actually working with their PCP and they send us the order. Or we'll get referrals from clinic here on patients that are starting to slide backward because patients in our clinics might be patients for decades because of their diagnosis. So we have a process for that, and we really still need to have therapy evaluate the patient so we know where they're at, where they were, and where we think we can get them. And our physicians in clinic will see the patient, and we use that information to tell their story and hopefully get authorization. It's a little more difficult, takes a little more time, especially for the medical complexity piece. Why do they need to be in an inpatient setting when they're currently at home? But that is something that we are seeing more.
Yeah, I found our process from admitting from home very smooth on my end because I was like, I saw the patient. Ooh, you should come into inpatient rehab, and then I'll email Holly, and it was like, oh, patient's here.
Easy button.
It's like, you are definitely our easy button.
Good.
It does come up, though. Even lately, we've had a couple, surgeons reach out to us and say, hey, I operated on this patient last week. They're just struggling more at home than we expected. What do you think? Can you give this a try? And so it does. The wheels have to turn the right way. We have to find a way to get therapy evaluations, and physician sign off. Sometimes we arrange for the patient to come in to be evaluated by their physician to kind of get that sign off for clinical need, but it can happen.
So you're being when you say the physician, is it you guys are like PM&R docs, or is it the surgeon?
Sometimes it's the surgeon.
Wow.
Yep.
And then if they can't get into inpatient rehab, you can still offer something to help
Right.
patient and family.
Right.
Yeah. How about, Chris, you see all these consults and you send them to Mary Free Bed where they're treated by one of our colleagues. And what is that like? So, do you get some comments back, well, I don't know if this patient was ready, or I wish this would have been done first, and how do you make sure, again, the patient's coming at the right time and enough things are tidied up? Because we want to prevent readmissions back to acute.
Yep. Yeah, it's a great question, and our inpatient team is so good, so talented in all of these different subspecialty areas. We see that the best way to navigate these transitions from acute care to post-acute care is consistent evaluations on our part, seeing the patient day after day and maintaining communication as much as possible. These are sick patients that are coming to inpatient rehab. As you guys know, patients are always getting sicker, coming to inpatient rehab. The population of IPR patients is getting sicker. And so some patients will develop an infection, right before or during or right after the time they come to rehab. There will be complications. This is a reality of our patient populations. So we try to maximize communication on the front end. When things don't work out for some reason, we keep that line of communication open. Holly and I meet with Dr. Smith and Dr. Brynsma every month to just go over a list of cases that, for some reason, some complexity came up, and we go over the cases and we all try to improve from it.
Yeah. Personally, I get like so sad when I get that feedback as like one of the newer consoles. I'm like, oh no, I did do something wrong. But like, I love your answer. It's the communication, like constant communication, like here are my thoughts, especially with our patients on ventilation. I think that's when the communication has to really start ramping up very early on. And then it goes back to earlier consults, because then you're prepared, you're watching the pattern, you've already communicated to the pulmonologist here or the respiratory therapist here, and they feel more prepared too. And it's kind of like supporting both teams, like yes, our team in acute care, but also our team here being like, okay, here is the patient and this is what we've done. You already know about this patient because I've knocked on your door so many times already. And I think that whole process makes a huge difference.
Well, and I think of it, when I see a consult, even from the very beginning, early on, I always think, today, tomorrow, where is this patient better off, in acute care or rehab? And, initially it's in acute care, and then at what point are they better off in rehab? And they might be ready medically, but they're still seeing 5 different specialists, which is at a different hospital. Even if it's just a mile away, that's a long mile. And sometimes they're better off having those specialists around. So you weigh a lot of things. And sometimes, the family is scared to leave acute care. Sometimes the family wants to get to rehab like right away when they're not quite ready. You weigh all those factors.
Yeah. What we do try to do on our end is kind of predict and prepare for those, objective things that we can catch ahead of time, that could cause a clinical complexity, when the patient comes over. We've developed a checklist that we've shared with our liaisons as well, to provide guidelines on, on emerging leukocytosis and on metabolic derangements and, making sure to look for any underlying pressure ulcers, all of these things that can really derail a rehab stay. The things that we can catch ahead of time, we want to make sure we're catching those things. The most common reason for transfer back to acute care setting from our hospital is a change in neurostatus, which can be kind of inherently unpredictable. But we do want to prepare for everything that we can possibly predict. Anything to add to that, Holly?
I think the handoffs that are provided day of admission at times are really helpful too. I know you call the attending sometimes, or liaisons will send an email, just a heads up. We saw this, we know, but this is the patient's normal baseline.
Yeah.
The extra eyes on the patient in the morning before they admit is helpful. But again, sometimes things happen and you just can't predict it.
Yeah, I think it's an important point too that, we try to minimize return to acute. We try to catch everything we can ahead of time, but we know that it is going to happen. Nationwide, I think it's about 10% of acute rehab patients will transfer back to acute care at some point. And I think is it 10% that also transfer back to subacute rehab at time of discharge,
Nationally,
something like
yes.
that nationally. So that, that's about 20% of patients total. So if we have 0 patients going back to the acute care setting, it probably means that we're missing patients on the front end, patients who would really benefit from inpatient rehab. So, we balance all of these things. We prepare as well as we can. We communicate as well as we can. And then we look for ways to improve.
I think knowing that 20% actually helps me as a consultant. It's oh, okay, so it's okay. Mm-hmm.
Yeah.
Yeah, because you don't want them to linger over in acute care longer than they need to, for every number to look perfect. Okay, now you can come to rehab. Well, that's a few days then where they've missed out on intensive rehab and probably going home later, overall than they would have.
Yep.
Yeah, so you got to find the balance, and like you said, unexpected things come up, especially with the neurostatus.
Right.
Yeah.
Right. I will say having our own internal medicine team has been really a game changer for us. It's allowed, our physiatry teams to really zone in on managing physiatry areas of care, along with the kind of the medicine areas. But having those specialists within internal medicine, I think has allowed us to, I don't want to say, take some chances where we wouldn't before, but to be a little more comfortable with these specific areas of clinical complexity, that maybe we would previously wait another day on, wait 2 days on before coming here.
That's a nice little shout out to Yuna's new husband.
Go, Nick. He's going to be very happy. I'll tell you that.
Okay. We owe him.
We have, and we're fortunate to have the pediatric hospitalists from the local acute care where we get most of our patients, Helen DeVos Children's Hospital. Their hospitalists come over here and every day and help us manage patients, and that helps patients get here at the right time because they're talking to their buddies over there, and it also helps minimize returns to acute because they can manage a lot of these things, or again talk to their specialists over there about what to do.
And it helps the family too, I realize. When I say you'll be being evaluated by the exact same hospitalist team here, so there as well, and that reassures them a lot.
Yeah.
Well, I think that was great discussion. Thank you guys for joining us. Any last comments?
I think we just love what we do, and
Well, I can tell that. Yeah. Yeah.
yeah, we like to keep the door open for patients that need us.
Yep, and I would say for patients and families, if you find yourself in the hospital and you've seen a functional decline, advocate for yourself. Ask for PM&R. You never know, when you or a loved one is going to qualify for some additional rehab attention and care. So it won't always be presented to you. So be willing to advocate
That's
for
a good
yourself.
point. Yep.
Well, thanks so much for coming today. We really appreciate you guys and all the things you do, truly.
Thanks for the invite.
Thank you both.